Welcome to OB-GYN Illustrated. I'm your faculty and author of OB-GYN Illustrated, Dr. Tessler. We're going to go ahead and go through the book and talk through some of the illustrations that are in it. And I just wanted to tell you a little story of where it came from. OB-GYN Illustrated was my notes. It didn't look like this when it started out. It was pen and pencil and highlighters for the color. But over time, people started saying like, wow, those are really helpful, or I really like the way you teach that. So then I decided I'll teach myself how to draw digitally and I will make a book. So there it is. It's now in its sixth edition for the 2024 OB-GYN Illustrated. And I know this doesn't look like a book for everybody, but I promise you, I've had people take their exams, come back to me and say, this book was not for me. I don't learn this way, but I just want to let you know, I definitely got a question right because I remembered a picture from your book. The book is created from all the things people tell me they wish they would have known more about, or things they wish they would have studied, or found an easier way to remember. So it's very directed at high yield information and what you need to know. It's a great book to sit back with when you're done with heavy reading, or you're just not in the mood to get into heavy studying and just kind of learn things a different way. Everybody's mind does better when it takes in input a couple of different ways. So let's go ahead and start taking in some information and go through the OB-GYN Illustrated. Before we get started, remember the disclaimer, copyright and trademark for Dr. Wall's OB-GYN board prep. Reproduction and distribution in any way is prohibited. The OB-GYN Illustrated is on file in the National Library and is copyrighted. As we go through the book, you're going to follow along with me. You'll see a small OB-GYN Illustrated book up in the corner, and the page number will be listed for you for the page that this is found in your book. So follow along with me and let's learn some great high-yield information. Okay, let's start out in the subject that everybody's good at when you get out of residency, right? You're a master obstetrician when you finish residency and probably the best in your careers at that point. But let's start there and get some good facts. All right, on page 4 of the OB-GYN Illustrated, you're going to find fetal circulation. Now, fetal circulation questions can be a little bit more difficult if you think about where we're asking the question about. Is it in the fetus or in the entire fetal circulatory system? So remember, inside the fetus is a little bit different for oxygenation and deoxygenation versus asking for the entire system of fetal circulation. The umbilical vein is feeding that high oxygenated blood from the placenta right up to the liver. And you're going to have that first bypass, that ductus venosus. Ductus venosus is going to bypass that liver and try to mix with as much of that blood as it can to keep it oxygenated up to the heart. Remember, when we get to the heart, we're going to enter in that right atrium, and the bulk of that oxygenated blood is going to shift right over through foramen ovale into the left atrium, and then, of course, the left ventricle, and being pushed out to the rest of the circulation. That blood that doesn't get pushed out that way ends up in a little bit of the pulmonary circulation, and it can bypass that with ductus arteriosus. Now, you may also see that there's the color key on the right bottom side there that's oxygenated all the way down to deoxygenated. So if I asked you, where is the most deoxygenated part of the fetal circulatory system? That's the umbilical arteries. That's going to be the farthest point away from any oxygenation source. It's going to definitely be the lowest. So that's going to be the lowest O2 in the umbilical arteries. But if I say, where's the lowest oxygenation inside the fetus? Now you can talk about the return from the IVC, but that's not as commonly a question as talking about the hypogastric arteries because that's on the exit on the way to the placenta. Placenta is found on page 7 of the OB-GYN Illustrated Guide. And this is a question about what crosses. These are great questions to write. They're pretty straightforward facts, but if you don't know them, they can be a little bit more difficult. Now, some things to remember when you're doing your terms for the placenta is things like bulk flow. That's water. That's a pretty straightforward and easy one. Things that I would pay attention to is things like oxygen can cross through simple diffusion, electrolytes and ketones, and also alcohol. Now, things that do not cross are up here, and that's going to be your prednisone, heparin, IgM, because it's a big macromolecule, and glucagon. I want to pay attention to this yellow area right here. That's one that sometimes people get confused. Facilitated diffusion, I think of fructose. Fructose, facilitated. The F's go together, and then I know fructose is one of those simple sugars. Fructose, sucrose, glucose, those are all facilitated diffusion. I don't want to mix those up with active transport, which is more like my heavy things I think of, like elements like calcium and phosphorus and iron. Endocytosis is IgG. Remember, it's got to get inside a bubble to head to the other side. Now, down at the bottom in the middle, you'll see placental hormones. These are pretty high yields. You want to know about these hormones. You want to know what they do. This is the placenta sending things out to control all of the functions of the body. So it's really important to understand what they do because they can also be part of pathological processes. On page 8, join me for hemolytic disease of the fetus and newborn. This is going to be helping you to remember those Rh antigens. Now, there's tons and tons of antigens, but these are the most common that you're going to run into, especially for examination purposes. The big capital D is the most common. You deal with that all the time. It's what we use RhoGAM for. You're familiar with this one. Now, the one to the left of that, that's going to be capital E or big E. Big E is the second most common in the United States. However, other parts of the world, it's actually becoming more common. On the right-hand side is that red C, and that red C is for capital C, which is another Rh antigen. Not as popular as the other two. Now, we've put these on top of a table, and it's like estimated date of confinement, right? EDC, you can remember that. And then underneath the table, only two of those have a leg to stand on, which means they exist, lowercase e and lowercase c. There is no lowercase d. At the bottom, you're going to see some of those things that cause severe hemolytic disease, and that's going to be anti-Rh big D, like we talked about, anti-Kel, also known as K1, anti-Rh big E, and anti-Rh big C. Now, there's all of those other ones that are out there, like Duffy and KID and Kells and all of those that are out there. And there's a lot of things to learn about those, and we'll talk about that in the exam. Aneuploidy risk. This is kind of a neat thing to be able to do. It's on your OB-GYN Illustrated page 8. And if you can get this down, it's kind of like you can come up with things in your head that people are like, how do you remember all these numbers? Well, I'm going to show you how you're going to remember them. You just have to really know this part of this image, and you're all set to go. So know that it starts at 30, and it's every 5 years after that. So 30, 35 years age, 48 years of age, 45 years of age. Under 30, you need to know 1 in 1,000. And under 35, you need to know 1 in 365. Because if you go to the right of those numbers, you'll see I just take off the last digit, and I've got 1 in 100 and 1 in 36. Now going down from there, I just have to cut those values in half, and boom, I've got any chromosomal abnormality chance of that with those age groups. So pretty cool, neat thing. All you got to remember is really these numbers right here and the ages that they apply to. Twins. This is Dr. Wall's famous way of explaining twins, and it's a great way to remember them and think about them because it helps you with some numbers that go along with them too. Now up at the top, we have the birthing presentations where we have vertex and we have our breeches and then our mixed presentations. And you can see that the majority of those are able to be delivered vaginally. So that's kind of going to be 2/3 and 1/3. Now, the discordance formula is for you on the very far right. That's large minus small over the large, and that's how you get the discordance. And we do talk about that in the exam as well. Now, when you come down here, you're going to be talking about dizygous and monozygous. So remember, when you're dizygous, that's 2 sperm, 2 eggs, and that's 2/3 of the multiple twins pregnancies that we're going to see. Now, monozygous is going to be the 1/3. That's going to be 1 sperm, 1 egg, and that splits into a multiples pregnancy. So we have our ability for the first part there at 0 to 3 days, which is diamnionic, dichorionic. Monozygous can be that, and it can be all the other things. Dizygous can only be diamnionic, dichorionic, and that's 0 to 3 days. Oftentimes, this is a fun thing to ask about, which is fused placentas. People think, oh, it's fused. There's no way that can be monozygous. It's a dizygous, right? Be careful. Make sure you're checking and making sure that you know it's a monozygous. Next up is 4 to 8 days, which is diamnionic and monochorionic. Again, we're going to see 2/3 there of those pregnancies. And then 9 to 12 days gets us into monoamnionic and monochorionic, and that's going to be less than 1%. Following that pregnancy, we get to 13 plus days, and that's going to be your conjoined twins at less than 1%. And remember, thoracophagus is the most common way that they're joined together. So when we get to that 13 days, 13 is like an odd number, a strange number. So we get those strange connecting twins, the conjoined twins, and that's going to be a different presentation. Thyroid in pregnancy is discussed on the OB-GYN Illustrated page 11. So let's take a look at that. We'll start with the physiology of the thyroid in pregnancy. The first 12 weeks of pregnancy, there is a ton of beta HCG. It's around 100,000 at 10 weeks and goes up a little bit from there. That beta HCG has a like alpha subunit to TSH. That means beta HCG can interact with the maternal thyroid just as if it was TSH. So therefore, we got a big jump up of our T4 being put out. And that's the reason we have decreased TSH in the first trimester, which takes us to a euthyroid state if there's no pathology going on, because we're going to see that TSH come down because it's like, wow, we're really, really active here. Don't need any more TSH. So that's going to be the physiological changes that we're going to see in pregnancy that go along with that. With all that activation, we also see the maternal thyroid increasing in size. It can increase up to 40% during that pregnancy in size. So don't jump on those big thyroids and think something's going on right away. That T4 is really important to be elevated because that T4 is going to transfer over to our pregnancy and get to our fetus. The T4 is going to go through the placenta of the pregnancy, and that's going to have high deiodinase activity, meaning it's going to take one of those iodines off and take T4 down to T3. T3 is super important. It's needed for central nervous system development in the fetus, and it's needed in that first 10 to 12 weeks of pregnancy because the fetal thyroid does not come online until about 12 weeks. So otherwise, if that T4 wasn't high and getting through and turning into enough T3 to develop that CNS system, we would have some major problems. Let's talk about a rare but scary thing that can happen in pregnancy with thyroid pathology going on, and that's going to be thyroid storm. This is when T4 goes way too high and it causes a hypermetabolic state. Now you can use TSH and T4 to diagnose it, but I'm not going to sit and wait for the lab to come back while my patient's looking really bad medically. So avoid delivery if unstable because you want to try to stabilize these patients first. They're not good candidates for surgery. Now, fever, tachycardia, and central nervous dysfunction are some of the biggest signs and symptoms that you're going to see. And I'm telling you, these people are usually very obvious with what's going on with them. This is not a subtle thing that turns on. This is a big, scary thing. So when we're giving our drugs, just remember PID, not pelvic inflammatory disease, but it is helpful to remember. That's going to be your PTU, your iodide, and your dexamethasone. PTU is given first because it has to be separated from iodide, but it has central and peripheral blocking mechanisms. That's why we put it up front because it has both. Iodide only has the peripheral blocking mechanism, so it's going to go second. Now, if someone had an allergy to iodine, what would you do? You can give them lithium carbonate. That's a useful piece of information. Following the iodide, we're going to knock on that dexamethasone, and then I'm going to talk a little bit about beta blockers. Beta blockers are going to be given anytime in thyroid storm when the heart rate reaches 120 or greater. When it gets there, you want to be able to give that to the patient to keep that heart rate from becoming an arrhythmia. That's fast and it's going to cause backup like pulmonary edema, and there's going to be a lot of complications that develop from it, and it can actually become scary arrhythmias as well too. So make sure that you understand PID is the order we're giving, lithium carbonate is an alternative to iodide for allergy, and beta blockers can be given anytime in that algorithm. And also cool about beta blockers, they also have a conversion blocking mechanism peripherally. DKA, another scary thing that can happen in pregnancy or in general. Diabetic ketoacidosis is showing by tachycardia, acidosis, and polyuria. Some people remember TAP, HHH, to remember things about DKA. Now with that tachycardia, acidosis, and polyuria, you're going to see hyperglycemia, hyperkalemia, but hypovolemia. Don't get that one mixed up. But you'll probably remember because you know the first thing you're going to do is slam them with fluids and give them some more fluids after that. Once they start to stabilize, of course, you're going to start giving insulin, electrolyte replacement to get those things back online that were a problem before. And then, of course, you're going to support them with whatever care they need. And this is always done or usually done in the ICU or a higher level of care. Now, the pathology is up there in the right corner for you. It can be important if you don't know anything about it. But DKA in pregnancy is the little box on the right. That's going to be that we remind you in pregnancy, it can be insidious and have a very rapid onset. That means blood glucose elevations do not have to be 450, 500, 600 before DKA is triggered. This can actually be triggered at blood glucose levels that seem very normal for people with bad glucose control. So like 200 or 250. Extra caution should be given around times that you're giving steroids for maturity or beta-symptomimetics. These things can drive up glucose and bring on a very quick diabetic ketoacidosis if not monitored. When you have a DKA pregnancy and this is going on, you're going to want to keep continuous fetal monitoring going because this will and can cause fetal acidosis in that pregnancy. That's on page 12 of your OB-GYN Illustrated Guide. Join me on page 14, and that's going to be viability. Now, there's 4 things that you need to know about viability, and this is really important. Not only is it like every 4th phone call you get from an ED, but you also want to know how to do this and make sure that you can answer questions about it for examination purposes. So I always think of it this way. It kind of helps me out. I think of the numbers getting bigger, and I think of things getting more complex as I go through the 4 criteria. So let's start at number 1. That's going to be a crown rump length of greater than or equal to 7 millimeters with no fetal heartbeat. Next up in 2 is a mean sac diameter greater than or equal to 25 millimeters, so a bigger number than 7, and there's no embryo, so more complex and bigger structure than fetal heartbeat alone. Now moving down to 3, we're going to say greater than or equal to 2 weeks post-scan with a gestational sac and no yolk sac. That's the important piece. I also use 2 weeks here instead of 14 days because 2 is a smaller number than 11, which is the criterion 4. So greater than or equal to 2 weeks post-scan with a gestational sac and no yolk sac, no fetal heartbeat, and no embryo. So more complex, more things added together than the criterion 1 and 2. Criterion number 4 is greater than or equal to 11 days post-scan with gestational sac and a yolk sac. So again, we got more things added on and a bigger number technically than 2 weeks for criterion number 3. Questions are always famously known to be asked by exam writers to say that the numbers are just messed up. It's going to be a greater than or equal to 23 mean sac diameter, or there is a heartbeat present, but the sac looks oblong. So make sure you're meeting these criteria or it is not a viability issue. On page 15, that's coags in pregnancy. Let's take a look and make sure we know what goes up and what goes down. We do talk about this in the exam, but I'll tell you again, know which things are procoagulants, know which things are anticoagulants. When you're talking about pregnancy, the big anticoagulants are protein S and protein C. Protein C stays the same. It's continuous. That's how I like to think about it. Protein S is going to go down, and protein S is decrease in pregnancy. And I just think it's a sucky thing anyways, because it's hard to measure in pregnancy. And so protein S goes down with protein S. 13 and 11 protein S are all going to go down. And then staying the same with protein C, we have 2, 5, and 9. The other things are all going up. And if you can remember the going down and stay the same, you can remember what's a procoagulant, what's an anticoagulant, you can know that everything else is going to be a going up, which is a lot easier to remember than all of those numbers as well. And then easier enough, everything that goes up is also a procoagulant. Thrombophilia. This practice bulletin is so hard to read and it's so hard to get the information out of. So I've put it all in one place for you. This is the risk factors. This is the things you have to do for them. This is the dosage of the medications and how long you're going to give them and increasing them in trimesters. And I just want you to pay attention to when there is a clot and when there isn't. So all of these things in the top table in the orange and yellow are no previous VTE. But let's take a look at our little group of clotting blood cells at the bottom. The clot thickens if there's a single previous episode of VTE, not on long-term therapy for it. Both high and low risk will require either prophylactic or dosed low molecular weight heparin or unfractionated heparin in antepartum and greater or equal therapies in postpartum. These individuals cannot have surveillance. That's what they're telling you. They can't have surveillance. So don't fall for that because you're like, oh, wait, that was a long time ago and they're not on therapy for it. They're fine. Nope. That's a low risk, but it still is going to be somebody who's going to get either prophylactic or dosed during the antepartum and postpartum period. This is just some of that testing that goes along with those thrombophilias. And a lot of people are like, oh, what about if there's a thrombus? What about if they're on treatment? I'm going to tell you what's really important here. First and foremost, the one that can be always tested for no matter what is the DNA testing for factor V Leiden. Factor V Leiden is also very, very common. So it's a great one to be asked about. So that DNA testing, which is the most common done for this, not the assay, is going to be for factor V Leiden, and it can be done no matter what, and it'll give you a result. The other one that can go all the way through no matter what is going to be another DNA analysis, which is PG20210A, the heterozygous form. So when you have that, it doesn't matter what's going on, that can be tested for. So I would know those two. Those two are really important because they can be tested for no matter what. I would also remember to point out that protein S deficiency is a little harder in pregnancy because the levels decrease each week, causing lower reliability. And they have adjusted scales that are out there. I'm aware of perinatology.com. OB-GYN Illustrated, page 17. There's your testing. Peripartum cardiomyopathy has been a hot topic, as well as cardiovascular disease, both in women who are not and women and patients that are pregnant. When it comes to peripartum cardiomyopathy, we want to remember this is a rare disease overall, but we're seeing it more and more. This is going to happen during the last month of pregnancy up to and including 5 months postpartum. That definition is really important because it either brings it in or takes it out as a differential. Speaking of differential, watch out for these mimicries. They look a lot like peripartum cardiomyopathy, but they're not going to have all of the things to qualify for that left ventricular peripartum cardiomyopathy disease process. This is much higher in certain patients, age greater than 30, and individuals of African American descent. Multiples, preeclampsia, postpartum, and hypertension histories increase the risk as well. And cocaine use or greater than 4 weeks of beta agonists are also things that bring on higher risk. Now remember that ejection fraction is less than 45%. Less than. Don't miss that part. It's really important. Pathology, what I would know is we're still not completely there with it, but things like impaired VEGF signaling, prolactin being part of it, and enhanced oxidative stress, those seem to be buzzwords that go around peripartum cardiomyopathy. One of the newer ones you hear as a buzzword is FMS-like tyrosine kinase. Now remember, for treatment, you're going to do all the things you can for cardiomyopathy, but you cannot treat with those things that cannot be given in pregnancy if the patient's still pregnant. So be careful and watch slowly in those questions to see if there's something that may be trying to trip you up. Amniotic fluid embolism is an extremely scary thing to happen. If you've gone through this process, you know what I'm talking about. It's a bad OB emergency. It's rare, but it's catastrophic. Amniotic fluid emboly is a possible pathology of the amniotic fluid entering the maternal circulation. It causes a gigantic anaphylactic reaction based on inflammatory mediators reacting to that amniotic fluid. The hallmark of this process is going to be that cardiovascular collapse. All of a sudden, your patient feels dread, and then they're just out. And you have to act fast and react to that quickly and recognize that you're probably dealing with an amniotic fluid embolism. There's 3 arms of the amniotic fluid embolism pathology, and it's really important to understand those because that's also the processes that are going to go forward as you go through the pathology. Number 1 is pulmonary systemic hypertension occurs. Number 2 is decrease in systemic vascular resistance and left ventricular stroke work index. Number 3 is going to be lung injury and coagulopathy. So these 3 main phases are what you're treating, they're what you're targeting, and what you're trying to do for these patients. Now, first and foremost, these patients need to be intubated and oxygenated. It's really, really important to remember that. The patients that are more risk for this are going to be things that are fast and furious, precipitous birthing, abruptions, induction of labor because we're pushing them forward fast, uterine rupture or cervical lacerations. So things that are bleeding quite a bit, things that are going fast, and things that are intense. That's going to be your biggest risk factors for amniotic fluid embolism. Page 19. Page 21 takes us to hepatitis B. A lot of people really freak out about hepatitis B, but it's not bad. Let's go through it quickly and make sure we understand. First and foremost, know that IgM and IgG are always going to mean very specific things. IgM is an acute phase. If they have IgM present, they're in an acute phase. The A from acute fits into the M nicely, so you can remember that. IgG is for chronic. If there's a chronic development, IgG will be there. And the C from chronic fits into IgG, or into the G of IgG. Now, looking at the different forms of hepatitis B, let's notice first that there's 3 of them that have C's in them. So that's important. We also have the acute phase and the vaccinated. Vaccinated's easy. It just has immunity. Immunity is the HBs antibody. So that's all that's going to be present. I just think of getting that 1 shot at a time, and that's what it's giving you in that 1 shot at a time is immunity, which is the HBs antibody. Now, there's another thing that has that immunity antibody, and that's going to be cleared. But cleared is also going to have an IgG because that was a chronic process that they no longer have the antigen, but they have this antibody present, and they still have that proof that the disease was there, which is IgG. So point that out to you that it's anti-HBC, IgG is going to be there. Now, carrier, that's going to take us back to antigen land. So carrier is going to have the antigen, but they're also going to share that commonality with cleared. So cleared has the immunity, carrier does not, because they're carrying it around still. So the carrier has that HBs antigen present now. Let's add on to chronic and make sure we see what's going on there. So again, we're going to have that antigen present because there is a disease. And we're going to have that IgG because it's been processing. It's a chronic disorder. So that's the easy one to remember. IgG means chronic. And then we have the HBe antigen, which means we're infectious. So as you can see, it is easy to pull apart which ones are going to have this and which ones are going to have that. So remember, the three C's all have IgG. That's all that's going to have IgG is the three C's, chronic, carrier, and cleared. So if you can get that down, you can knock out some answers just by knowing that. Now let's talk about the other one there, and that's acute. It's going to have the IgM.
Okay, I found this on the web for it's going to have the Asia. Check it out.
It's the only acute phase. Therefore, it's the only one with IgM. So if you have an IgM showing up, I don't care what IgM it is, that's going to be the acute phase. So one IgM is acute. If it has an IgG, it's one of the three of the C's, which is chronic, carrier, and cleared. And vaccinated, you're never going to forget because it just has the one thing. It's the only thing that has one thing, and that's going to be the antibody for immunity. Page 24, these cute little babies are showing us Erb's palsy and Klumpke palsy. Erb's palsy is C5, C6. It's the higher injury, so it's higher on the page. This creates the waiter's tip, where you see the arm turned backwards and the hand behind, trying to get that more money out of the person who she just carried all of that food out to. So that's going to be the waiter's tip hand. Now, Klumpke palsy is a lower injury. It's C8 to T1. It causes the claw hand. So the claw hand, as this baby is showing you, has a little lobster claw, is going to look kind of like a claw. Klumpke palsy also does not happen from the same mechanism of Erb's palsy. Erb's palsy is from you yanking that head over away from the shoulder and pulling that upper part of the brachial plexus, causing stress there, which causes C5, C6 injuries. Klumpke palsy is actually if you put your arm straight up in the air, like you're waving to somebody, and you were to fall off a roof or a tree branch and you catch the roof or the tree branch to try to hold yourself up, that quick, strong pull of that arm upward is going to stretch the bottom part of your brachial plexus, which is going to cause Klumpke palsy. So this is something you actually see people come into emergency rooms or offices with, and they don't understand why their hand's having a problem. APGAR. Everybody loves APGAR, right? Gets a little hard from some folks, and I want to tell you it's actually super easy. It's super easy because you do it all of the time. It's catching a kid. So let's go through that process and make sure we know what all the APGAR pieces are. First and foremost, when you catch that kid, we're not paying attention to skin tone right off the bat. The first thing we want to know is that kid floppy or not. So we're looking for tone. So you've got that kid in your hand and you know that it's got tone or it doesn't and what that equals. So tone is first. Then what do? We look at the kid and see if they're pinking up a little bit, right? Because we don't want them to stay blue. We want them to pink up. So there's your two things that you're going to do, tone and appearance. After that, baby looks good. Let's toss it up to mom or the pregnant patient. And that's going to be heart rate and respirations. That's going to be your nurse. So this was you down here. And this is your RN up here doing heart rate and respirations. Now comes mom's part. Mom's looking for that grimace. Grimace, and then the best thing ever, a sneeze. Everybody loves that newborn baby sneeze, which is the highest APGAR score. So mom's looking for that. The RN's looking for heart rate and respirations. You're looking for activity tone and their skin appearance. And if you just think about that birth, it is really easy to know which part is which. Preventative in office. Best breast facts. Make sure you know a couple of things on this very well. First and foremost, green discharge is ductal ectasia. Blood is usually intraductal papilloma. Those are pretty straightforward. Remember that upper outer quadrant is really important, and there's that pectoralis minor there. The one underneath the minor is the level 2 lymph nodes, and it's 1 and 3. So I just remember that the 1 is closest to the breast, and the 3 is going higher away from the breast. So you're starting at the breast because it's a breast thing, then you're going upward and away, and that's going to be 3. Here's some breast normal and pathology lesions for you. I would be very comfortable with knowing where these things are, where they come from, and maybe knowing a little bit about the treatment and diagnosis of them. You don't have to be an absolute expert in this area. I just want you to be aware of them. So if you see things that are about these in exam questions in the future, you'll be able to at least recognize the words and know a little bit about it. And that's usually enough to get you by. Now on page 32, this is the Women's Health Initiative study. First and foremost, if you've ever read this study, I'm sorry. It's confusing. There's a lot going on, and they already know that there was something wrong with it, and they've already apologized and gave out the new data. The problem with this study was we did it on people who would have never had hormone therapy in the first place, and it stopped for clots and stroke. I'm going to teach you how to know what the Women's Health Initiative study found very, very easily. You're going to be upset because you tried to learn this before, or you have that really fun attending who likes to ask about it at 3 a.m, but you're going to always have an answer now because it's actually pretty easy. As you can see, there's 2 columns. These were the 2 arms of the study. One of the arms was 2 things, estrogen and progesterone. The other thing was estrogen. Estrogen is estradiol in this case as far as the treatment, so E2. So there's 2 things that resulted from the estradiol arm. And you know one of them because it was one of the scary things, which is clots and strokes. The other thing is something we know about estrogen no matter where you're at. And that's going to be that fractures are decreased by estrogen's presence. So if you are like, I know 2 things strongly about this study, what it was shut down for, and I know for a fact that estrogen decreases fractures of bones, you're all set with estrogen. It just has those 2 things, E2, estradiol. Now the estrogen progesterone arm looked at more things, so it got more results from the study. That's going to be looking at breast cancer, clots and strokes, heart attack, colon cancer, and fracture. Now, how to remember what goes up and down? Well, you're going to put that red line in, just like I put in here. Everything in this part up here is kind of in the upper body. So breasts are on the upper part of the body, clots and stroke, we think about the brain, heart attack, the heart's in the chest, upper part of the body above the waist. If we look down below, I'm going to say below the waist, we think of our colon and our bowels as something that happens down there or ends up there. And then fractures, we always think about hip fractures, right? That's the big important one. So between those 2, those are things that are below the waist, and everything in the study went down. So as you can see, this is really easy to remember what went up, what went down, what resulted from each of them, and you're going to know the biggest thing, that clots and stroke ended the study. Lichens. Lichens is something everybody just starts pounding their head on the desk for, but I'm going to make it super easy for you. I'm actually going to solve all of your lichen confusion issues by doing one thing. That's going to be removing the word simplex from lichen simplex chronicus. Never again call it that. Just erase it from your memory. It is lichen chronicus. There is no S in it. It never existed. Don't put it there. It's lichen chronicus. So we have lichen sclerosus, lichen planus, and lichen chronicus. Now you can keep them apart in your mind and never return them again. Lichen chronicus literally explains what it is. It's any person at any age that's just scratching and itching and scratching, and over again, they get hyperkeratosis, spongiosis, and acanthosis, and that's going to make this pruritus that's just itchy and worse, and then they start building up lichenified plaques. Now, it's important to know that there's no cancer correlated directly with lichen chronicus, and that's going to be an important fact here. And then we also have the fact that it does not go into the vagina. Now, lichen sclerosus, let's head over to that blue column, is going to be people that are usually 50 to 60 or people that are really young. So it's going to be really young individuals or older individuals because it's got some relationships to estrogen. It also is going to be that classic figure of 8. So again, this is the only one with the S. Remember, lichen sclerosus. So if you complete that S, it makes the figure of 8. This is long-term. It can narrow the introitus. It's an autoimmune process and related to other autoimmune processes. So that's why we believe it is. Remember, lymphocytes are dealing with this process too. This can be in people with diabetes mellitus, people with rheumatoid diseases, or any of those autoimmune things going on are very common to also have lichen sclerosis. Now, this is rarely ever extragenital, which is unique to lichen sclerosis. This does present with itching as well too, pruritus, just like lichen chronicus, but this is going to be your porcelain white papules, plaques, fissures, and ulcers. So it has a very unique look to it, which is this whitening area or loss of pigment area in that figure of 8 pattern around the vulva and then down around the anal area. This does have a correlation with progression to squamous cell carcinoma, important to know, but it also does not go into the vagina. Lichen planus, this is the scary one, right? Lichen planus happens almost always in perimenopausal women. This can leave scars and it can close off the vagina. If it can do that, that means it can be inside the vagina. So we think of the vagina as a hanger, and the planus can go into the hanger or into the vagina. Now this presents with pain. That's a little bit more unique to the lichen planus process. This can also be an erosive lichen planus, which causes scar tissue and friable membrane. And remember, this has that reticular lacy pattern, and it can even have that shiny kind of pretty pattern that looks like a doily on a table. That's Wickham striae. It's actually kind of cool looking. So that's going to be lichen planus. Lichen planus also has a relationship with progression to squamous cell carcinoma. One other thing about this is these two words, pointed red apex and hypergranulosis. Those are words that just go along with lichen planus. So I would know those in correlation. Let's take a yeast vacation. Well, at least you would probably do that for fun, right? Well, let's go. We're going to jump on Canada Airlines because this is the other kinds of Canada than Canada albicans. The airline's going to take us globe-trotting, or globerata. So that's going to be our first part of the story, is that we're going globe-trotting. And I don't know about you, but if I'm going globe-trotting, I want to go somewhere tropical, so tropicalis. Now, when you get there, there's going to be beautiful ocean waters. You're going to want to take a cruise, and that's Cruisii. And then you can go ahead and jump on one of those super fun parasails and go across the ocean, and that's Parapsalasis. Now, down under the water, deep below, there is a Lusitania, which is a sunken ship, and that's going to be Lusitanii. So these are going to be your yeast vacation, fun ways to remember the other kinds of Candida that are not Candida albicans. Now, I want you to also pay attention to the table that's on page 36, just below this. That's going to be the things that don't and do respond as far as medications for treatment of these different kind of Candida. Now, something that I can give you to remember is going to be that Cruisii does not work with nystatin. So I always just think that you don't want to take a cruise at night somewhere new. You can't see anything. So no nystatin for Cruisii. The other one is you can pretend this is me, Dr. Tessler, sailing along on his parapsalasis or parasailing. I would be screaming terrified the entire time because that is not fun to me. So I'd be terrified, and that's going to remind you of turconazole. So those are two big ones to know that they don't work with those specific types of Candida. Let's head into gynecology and surgery. Bowel injury. You know most of these things are caused by entry. 40 to 50% of small bowel in our field is caused by entry injuries. Thermal injury is a great thing to write questions about because someone will probably tell you that, well, it's only if it's this bad or that bad. But if it is a thermal injury and we're talking about generalist standard of care, the best management will always be a resection. That resection should have 1 to 2 centimeter minimum margins around the site of injury. Poke injuries, even through and through, if they're just a direct poke injury, that's going to be just conservative management. So watch the patient for about 24 hours, make sure nothing develops, and they'll be fine. Now we know serosal is a single layer closure and full thickness is going to be our double layer closure. Now you can talk about parallel and perpendicular all you want all day long. I just remember I don't want to narrow the bowel. You don't want to shut that lumen down. So sew it so it doesn't shut that lumen down. You can shorten the bowel all day long until you get to short gut syndrome, but you cannot narrow the lumen. Page 42 brings us to ureter injuries. I hated these questions when I was practicing for my board exams. I swear I would get them wrong. I'd even remember the question and answer it like with the right answer that I remembered, and it would still be wrong. I never knew what was going on with these, so I had to understand it, and this is the easiest way I can tell you. 6 centimeters. The ureter at the ureter is a 6-letter word, and that is the important measurement of 6 centimeters because that's when you're within the pelvic brim. If you're within the pelvic brim, greater than or equal to 6 centimeters or less, if you're within the pelvic brim, you're less than or equal to 6 centimeters from the bladder implantation. The answer is always going to be a ureteroneocystotomy. That's what needs to happen. The ureter needs a new connection to the bladder itself. Now, that is commonly done along with a psoas hitch. Psoas hitch is bringing that bladder over to the psoas muscle to take tension off of that repair of the ureteroneocystotomy. GU repairs are all about tension. If they are free of tension, they will heal well and they will do very well on their own. However, if you have tension on them, that causes urinomas and other things that won't allow them to heal. Now let's take a look at the upper and middle third. That's the ureterosteomy. That's an end-to-end, usually done over a stent, but that's not the important part. So we're past that 6 centimeters and we're in the upper and middle third. So ureterosteomy is when we're leaving the pelvic brim and getting higher. This can be done with a Biore flap or a psoas hitch sometimes, depending on bringing that Biore flap over. The Biore flap is just taking the bladder and putting a cover over that new ureterosteomy or creating a channel with the bladder to create one. Nerves. These nerves get people all nerved up, but let's talk about them. It's actually not bad at all. First and foremost, if you're talking about the front of the thigh or the middle of that's going to be lateral femoral cutaneous or anterior femoral cutaneous. So it needs that femoral cutaneous words in it to be talking about anything farther than the inguinal ligament. So if they're talking about something down on the thigh or on the leg, that is no longer any of these 2-word ones that are up at the top. So lateral femoral cutaneous and anterior femoral cutaneous are covering the thigh. Now, with the ASIS to the pubic symphysis, we know that area has the inguinal ligament. So if these are around the inguinal ligament, the sensation is around the inguinal ligament, it's one of these 3 nerves. Let's start all the way out on the lateral. That's iliohypogastric. Iliohypogastric splays out like a butterfly around the inguinal ligament, and it's the first part of that lateral side. After iliohypogastric, we have ilioinguinal. Ilioinguinal is going to just go farther, and it's going to put another butterfly around the very top of the thigh by the inguinal ligament and carrying some over to the mons. Now, one in between there is going to be the femoral branch of the genitofemoral nerve. The femoral branch is going towards the femoral artery, and that's the femoral branch of the genitofemoral nerve. Now, if we follow the genital branch is going towards the very top of the vagina, and it's also going to be on the mons pubis. So this should help you out with knowing where these would be involved and which sensory deficits would be coming from each of them. And like I told you, if you're getting down here onto the leg, that's going to be something with the words femoral cutaneous in it. Pelvic vasculature. You must know your pelvic vasculature. I tell medical students all the time and my intern residents, give me a 13-inch part of the body and know it really, really well for gynecology and you'll be okay. You need to know where things come off of the aorta, like the celiac trunk at the level of T12, the inferior mesenteric at the level of L3. The right ovarian vein and left ovarian vein are different in their feedback to the vena cava. The right ovarian vein goes right back in. So I remember right ovarian vein goes right back into the inferior vena cava. The left ovarian vein feeds back into the left renal vein. So you can keep those separate in your mind. The renal arteries are just above that, and those come off of the aorta just below the superior mesenteric, just below the level of L1. At L4, we see the first bifurcation that we deal with, which is of the aorta into the common iliacs. That's going to be also where we see the middle sacral coming off that bifurcation of the aorta. Now, see the ureter crossing over on that common iliac when we become the external and internal iliac, the next bifurcation of importance? There's something else that crosses with that ureter. It's that blue superior hypogastric plexus. We're not going to get into what it does and all that fun stuff. My inner anatomist loves those things, but we're just going to know that that's also something that crosses at that area along with the ureter. Now let's head into the internal iliac and look at those super fun divisions, the anterior division and the posterior division. Now we talk about a way to remember the anterior division in the exams. That's the OUUMII, which tells you the first letter of the names of the things that come from the anterior division. I just think of things midline because it is mostly the things that are in the midline of the body that are served by the anterior division because it's literally physically where it ends up. But I also think of things that pass through things. So the obturator passes through the optoforamen, and then we also have things that pass through the greater sciatic foramen. There's two from the anterior division, which includes the internal pudendal and the inferior gluteal. Those are going to pass through the greater sciatic foramen. The one from the posterior division is going to be the superior gluteal, which makes it kind of easy. It's the internal pudendal and the two gluteals, which are kind of close to each other in anatomy, right? So those all go through the greater sciatic foramen, but only one of them continues on to go through the lesser sciatic foramen after bypassing behind the ischial spine. That's going to be the internal pudendal. You know that. That's where a pudendal block is going to be happening. Now, up in the posterior division, people say it's a little easier to remember because it's just that ILS. So I love science, I love whatever. Iliolumbar, lateral sacral, and superior gluteal are going to be our posterior division. Blood. Chance of infection is incredibly low anymore. So therefore, I don't even like to get into it. It's just low. It's kind of a ridiculous question to ask. Now, you need to know that the universal donor is O negative and the universal recipient is AB positive. Most common is O positive, which if you turn that, it looks like the sign for women. So it's easy for us to remember that O positive is the most common. The least common blood type is AB negative. Now, at the very top, a lot of people don't know about CMV in the blood supply. It's very common in US adults. By age 40, about 75% of us or more are exposed to it and are fine with it. But not all blood is screened for it for that reason that everybody pretty much has been exposed to it. And if you're healthy, it won't matter. Pregnant and immunocompromised individuals, though, they require CMV screened supply just in case they've never been exposed to it before. Let's head to page 46. This has been one of my favorite images that I've ever drawn, and a lot of people like it because it's just jam-packed with information you need, like what we screen whole blood for before we send it into all the other processes of making the things that we take from it. We also have whole blood that has plasma, platelets, WBCs, and red blood cells in it. If we spin down that whole blood, we're going to develop either packed red blood cells or fresh frozen plasma. So you'll notice there's an ABO by that fresh frozen plasma. Fresh frozen plasma is the only one that needs ABO typing. Everything else is going to need ABO and RH typing. So make sure you know fresh frozen plasma is the only one that's just ABO, or things that come from it like cryoprecipitate. Now, when we spin that down to red blood cells, remember that's going to be 250 to 350 milliliters of packed red blood cells. What you're going to expect from that is an increase of the hemoglobin 1 gram and hematocrit 3%. Now let's look at that fresh frozen plasma. 250 milliliters contains a lot of coagulation factors. Important ones, 2, 7, 8, 9, 10, and 11. Remember, does not carry oxygen. There's no oxygen carrying happening with your fresh frozen plasma. Now, if we thaw that out and we spin it down again, we get a supernatant. If we take that supernatant off, we're left with cryoprecipitate. Cryoprecipitate is about 40 milliliters and it's very concentrated. So it's big bang for the buck, because it's going to have all of these coagulation factors in it, very concentrated. And one of the big ones is von Willebrand's factor. So what's the most concentrated source of von Willebrand's factor? Cryoprecipitate. This is expected to increase fibrinogen 5 to 10 milligrams per deciliter, which is about the same as fresh frozen plasma. So you're getting more bang for a very small amount, 40 milliliters. Platelet pheresis occurs on that whole blood, and that's going to bring us to pooled platelets. Jumbo packs are usually given, which is 6 units of platelets. You're going to increase or set those platelets to go up by each unit about 10,000, so 50 to 60,000 for a jumbo pack. And also remember, we're back to ABO and RH typing. Clots. I'm just a science nerd, and I love stuff like this, but it is important to know because we deal with clots quite a bit. As you can see on the far left, we have the extrinsic injury. The two main systems that start out are extrinsic or intrinsic. The extrinsic injury is cellular disruption. So you can see they've actually have some damage going on to the vessel. That extrinsic injury is going to be 7A. So that's going to be 7, and 7 is just a number that's all by itself, and you're just going to remember that little 7 sitting out there all by itself in space. Now, the intrinsic injury, this is disruption within the vessel. This is things like VLDL causing buildup inside the vessel wall. When an intrinsic injury occurs, that's going to start with 12. The reason you're going to remember 12 is because I'm going to tell you 13 is all the way at the end. So you're going to remember 13 is all the way at the end. So intrinsic must start with 12 because the highest number is already used up. So we're going to go with 12, 11, 9, and then we know that 8 brings us over to perfect 10. We know 10 is going to be missing in the countdown because 10 is what starts the common pathway. So common pathway takes us to perfect 10. So that's how we're going to remember that one, that it's missing from the 12, 11, 9 countdown. 10 is going to go to 5, and then 5 is going to prothrombin and thrombin. That brings in our 13A at the 13th hour, or the very last moment of the day. And thrombin goes to fibrinogen, and both of those things come together to form fibrin, and thus the fibrin clot. This is a little bit on antibiotics on page 50. So let's head over there and take a look. This is your ribosomal activity. We won't go through all of the antibiotic things that are in the OB-GYN Illustrated guide here, but I want you to go through them when you have your OB-GYN Illustrated just sitting in front of you later. So make sure that you know things about antibiotics. This is a very, very high yield topic for our field. This is things that interact with the 30 and the 50 ribosomal units. We've also added in some of the things that go along with those antibiotics that are not super fun, like C. diff or thrombocytopenia and serotonin syndrome. And we've told you where they interact with those ribosomes. And then we've also shown you things like what comes IV and PO or intramuscular like gentamicin. Here's one of those antibiotic flow charts for broad spectrum antibiotics. Broad spectrum antibiotics are starting at the bottom like levofloxacin. You go up to your narrow spectrum, that's more things like moxifloxacin. Now, you're going to have coverage here with your anaerobes, and then you're getting gram positive, a little bit more increased there. But the important thing I want you to know is that Pseudomonas coverage is not there. Let's head over to page 55 and take a look at nerve injuries. Nerve injuries are really important and they're very high yield, and there's fun ways that a test writer can write questions about these or give you answer choices that are a little more confusing. Like if I just told you that you needed to know the genital femoral is L1, L2, would you recognize that if the answer was L1, L2 instead of saying genital femoral? Frequency also is important, and some of the higher frequency ones are femoral and obturator, which still does occur, but not as much as they used to. One of the more common ones is not on this chart, and it's peroneal. The reason is we go over it in the exam quite extensively, so we'll talk about it there. POPQ. Some people just literally shiver at the thought of POPQ. It's okay. I can make this really easy for you and tell you that questions that are generated when we write exam questions for POPQ are pretty straightforward. Either asking about the anatomy involved with certain parts of the POPQ system and what they may entail for the different types of prolapse that occurs related to them, or giving you a chart from the POPQ chart and having you figure out which part is prolapsing. Well, we have the anteriors that are in this green, the posteriors, which are in the purple, so that works out nicely, and then the middle column is going to be some of our measurements. So in that top row, you're going to have A, B, C. Pretty easy to remember. The bottom row, you're going to have A, B, D, like an ABD pad that they put on after C-sections to hold the wound pressure. The middle one is going to be H, P, V is what you're going to remember so that you can get the rest of the letters in there. So that's going to be your genital hiatus, which is the most reproducible measurement, the perineal body, which is going to be from that bottom part of the vagina all the way back to the anus. And then we're going to have total vaginal length. That's got to be measured in a supine position at rest. Just think about it. That's the one you're measuring everything else against. So you want to make sure you're giving them the best measurement and the best benefit of the doubt. So you want them to be measured in a supine position at rest. So everything should be non-prolapsed back to where it belongs when you're taking that measurement if possible. Let's talk about some of these points on the graph. So that's going to be AA first. AA is going to be 3 centimeters back from the hymen. That area is including the urethra. So AA is talking about the urethra. The next one is BA. BA is the area from AA all the way back to C, which is cervix and cuff. BA is talking about the bladder. So that's going to be your cystoceles. Now C is continuous. It's always going to be there because it'll be the cervix or it'll be the cuff. So it's the apex of the vagina. If a total hysterectomy occurs, you're not going to have D anymore. D is the posterior fornix and it disappears if you've done surgery. Coming around from point D, we're going to have the posteriors like BP. Now I want you to remember that BP is an important point because if we're talking about the prolapse in that area, that's enteroceles. That's not going to be your rectoceles. I know these pictures always make it look like it's really far forward and it's not part of the area that enteroceles would occur. But if you're thinking about where this would prolapse out, that's going to be your enterocele area. Now, when we get down to AP, that area is where you're going to experience rectoceles. Rectoceles are going to be closer to the entry point, the introitus of the vagina. Now, in the green and purple boxes on the side, that's correlating surgeries for the prolapses that you find from the parts of the grid above, correlating by color. That may be something that's important to know if they're picking out a certain types of prolapse when exam writers are writing questions, and you have to know what to do about it. I would encourage you to find the app about prolapse. It's a PopQ app that's out there. It's free. It's from one of the societies. And look at it a little bit. Look at what normal looks like. Look at what a really bad cystocele looks like. Look at what a really bad rectocele looks like. You'll start to see the pattern in the numbers and you'll start to be able to recognize them. That's a great way to study and keep yourself up on these things and be able to visually recognize what it can look like when the graph is in certain numbers. 57 is the other part of prolapse. This is Baden-Walker. Baden-Walker is more of a qualitative scale where you're in the clinic and you just say, this is stage 0, 1, 2, 3, or 4. 0 is no prolapse, so I don't even pay attention to it. I think of this scale starting at 2. 2 is the hymen. So if the most distal part of the prolapse is at the hymen, it's a stage 2. Now, if you go 1 centimeter up or 1 centimeter down, that gives you stage 1 or stage 3. So when we're looking at measuring for Baden-Walker, it's going to be 1 centimeter up from 2 is stage 1. 1 centimeter down, that's going to be stage 3. Now, stage 3 can be no more than TVL minus 2 centimeters. That's an important measurement to know. So like I told you, that TVL needs to be a good measurement because you're kind of measuring against it for the prolapse stage. Now, if the prolapse is protruding past at least TVL minus 2, that's stage 4. And stage 4 will eventually give to complete prostodentia. Gyn oncology. I'll tell you a funny story. Gyn oncology is how I've always said gyn oncology. And when I was taking my oral exams, my oral examiner said, you would refer this to another gynecologist? And I said, no, I would refer it to a gyn oncologist. They said, are you saying gyn oncologist or gynecologist? I guess my Midwest accent and fast talking pace told them I was saying gynecologist, but I will always now say gynecology oncologist. Disco Queen. You've seen Chemo Bear, Chemo Kid, Chemo Man, all kinds of chemo people, but you've never seen the Chemo Disco Queen. It's time for her to rule. Up on her head is her crown of disco, which shows you the nitrogen mustard's neurotoxicity.